presentation also. So this year we have wonderful sessions. Every month we have conducted the webinars on different topics, and I would thank moderators, Dr. Pramod Giri, Dr. Kishore Chaudhary, Dr. Datta Muzumdar, Dr. Abhay Kumar for their nice contribution and hard work. And I should thank Dr. Sarangote and his team to make give a good technical support. So
unable to start my video. No, but I can't. When I say start video, it is not doing. Oh, you started. Okay.
Okay.
Thank you. Good evening.
But now I can't hear anybody.
Okay, sir. Just you can see, sir. I will just share my screen. So for today's webinar, we have the speakers, Dr. Pramod Giri from Nagpur and Dr. Kishore Chaudhary from UK, Sheffield Hospital. And we have moderators, Dr. Pramod Giri and Dr. Sarang Rote from Pune. And we have the panelists, Dr. Sanjay Bihari from Trivandrum, Dr. Dilip Kiyawat from Mumbai, and Dr. Atul Goyal sir from Mumbai, and Dr. Dilip Kiyawat from Pune. Sorry. The topics for today's webinar are tuberculum meningioma, basics. To be taken care of by Dr. Pramod Giri sir. It will be for 20 minutes and there will be 10 minutes discussion. And the next topic will be high-grade glioma surgery, learning points from a complication, case presentation by Dr. Kishore Chaudhary. So the time for this will be 8:30 to 8:45, 15 minutes and 10 minutes discussion. With this short introduction, I hand over to Dr. Giri sir to carry on, sir. Dr. Giri sir, please.
Thank you, Milind sir. So we have just modified that. First, we will present both the cases, and then we will have the discussions and the experts' opinion, so that Dr. Bihari, who is right now in the flight from Delhi to Lucknow, he will also join at the end of the presentation. So I'm sharing my screen. So let's start with my first case. That is the presentation.
I cannot.
Hello. 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 Hello, Sarang. Can you hear me?
Yes, sir. Yes, sir. I can hear you. I think there is some problem in Kiyawat, sir. He is not able to listen. We will sort it out, sir.
So shall I stop or shall I start?
No, sir. You continue, please.
Can you see my screen?
Yes, we can see yours.
Yes.
No, so, see, we cannot see the screen. We can see you. You have to share the screen.
Can you see it now?
No, sir.
Now?
Yes, now we can see.
Thank you.
Thank you, sir.
So I'm starting with my topic, that is how I do it for the tuberculum meningioma. So we all know that tuberculum meningioma is a
I cannot hear anything.
Oh.
Sir, we are looking at it, sir.
Shall I continue?
Yes, sir.
Kiyawat sir, can you hear us? Hello? Kiyawat sir, can you hear us?
Kiawat sir, can you hear us?
I think he cannot hear. So,
Shall I
Giri sir,
continue?
please continue, sir. I think I will call Shubham to
Every neurosurgeon has a very much interest in this anterior skull base lesion. So this classical anterior skull base meningioma is actually contributes 3 to 10% of the intracranial meningioma.
सारंग मेरे को आवाज नहीं आ रही किसी की
And
भी
because of this suprasellar subchiasmal midline position, and with this intricate position,
Any
we
button
all
which I
are
should
very
be
much interested
clicking?
in taking out these lesions and enjoy the fun, what we want to say. The probability of
अभी इससे तकलीफ है क्या?
increasing the optic chiasm and the specifically the lesions
Go
with
back then.
hello,
ठीक है देखता हूँ मैं फिर से. All right.
hello, hello, Sarang, is it okay?
Yes, sir. Yes, sir.
Shall I start again?
Yes, sir. Please, sorry for disturbance.
Sorry, Atul sir, we are coming to the So myself, Dr. Pramod Giri, I am starting with my presentation, how I do it, the tuberculum celli meningioma, knowing the basics right. As we all know that this lesion is basically intricate in its location in the anterior skull base. And it contributes to 3 to 10% of the intracranial meningioma. The suprasellar subchiasmal midline position is really little. We will just go for little bit brief of the anatomy. Here you can see on the screen that tuberculum celli is actually located between the two clinoids, anterior clinoids, and we can see that it is forming the base of the anterior skull base and the hypophyseal fossa posteriorly to it. So this anatomical structure, it includes all the important structures which are actually entering the skull base. So we all are interested in actually taking out the lesion without disturbing the important structures around this lesion. So the clinoidals and the recesses we have to see when we will be seeing the video. So this is the basic anatomy. Here you can see that this is the tuberculum celli meningioma, which is actually in between the two optic nerves and just anterior to the optic chiasm. This is the diagrammatic representation. So this diagrammatic representation shows the location of the ICA. So coming to my case, that it is a 33 years old lady with the complaints of holocranial headache and right-sided complete visual loss. Only she was PL positive on the right side, but the left side vision was intact. Though the perimetry was showing some biotemporal immunity, it is mainly because of that left-sided light projection. We could assess that she was having biotemporal homonymous hemianopia. That is the classical presentation of the suprasellar location. So it was the temporal homonymous hemianopia was more on the left side than the right side because it's right. She has already lost the vision, like a right-sided only PL positive. This is a classical, well-defined, lobulated, uniformly enhancing and mushrooming over the tuberculum celli-based meningioma. This is classical presentation, radiological presentation of the meningioma lesion at this region. And you can see that the optic chiasm is lifted up and the anterior cerebral arteries and the origin of the bifurcation of the IC and MCA, they are seeing all push towards the lateral side, and on one side it is encasing. The dural tail is also seen on the sagittal cut, and you can see that the tumor is absolutely homogeneously enhancing. So we have a plan. That plan is right terminal craniotomy, right subfrontal and interoptic corridor, and trying to take out the tumor, that is the grade 2 excision of the Simpson's grade 2 excision of the meningioma. So here we have typically taken up the stereonal craniotomy and the subfrontal and interoptic corridor, which is maximum people, they generally use it. But there are variations. The experts, they generally go subfrontally and they try to take out. People like me, generally, they take the conventional one. And yes, definitely, I have been through to the literature, and it is said that the base paper is from the biggest series from the Atul who was showing that they have approached it subfrontally and they have shown some advantages also. So, sir, this is we are using the terional craniotomy and subfrontal interoptic corridor in this case. So this is the typical position for the terional craniotomy. And after taking up the bone flap in the base towards the sphenoid wing, we have to open the dura towards the sphenoid base, and we can see the structures on the diagrammatic representation like this. So once this way we opened up, then we have started retracting the lever retractor to enter the subfrontal corridor. So you can see that we are encountering to the tumor directly, which is typically the lobulated and vascular. I'm putting a patty on the towards the right optic nerve and one patty over towards the olfactory tract. So after applying and taking the frontal lobe little bit retracted, I started coagulating the base of the tumor. So this base and little bit coagulation of the tumor shows me the anterior skull base of the and the attachment and the vascularity of the dura can be clearly seen. So I started taking out the tumor piecemeal, and here after taking out the tumor piecemeal, we can see that it is quite vascular, though it is lobulated, but definitely it is vascular. And I'm approaching by little bit coagulating the base and then taking the tumor in piecemeal so that the steps should be repeated to internally decompress the tumor. So here you can see that I'm just trying to decompress the tumor internally, going all around and keeping all the structures protected with the quarter patty and taking out little bit more from the left side. So here you can see that the well lobulated tumor with the good arachnoidal plane, I'm trying to take it out from the left side of the anterior skull base. So little bit the difficulty in retracting, and so I started retracting it further to expose the subfrontal tumor and trying to pull the tumor in the field. Here I am trying to break the arachnoidal adhesions towards the right optic nerve, and gradually I am trying to pull the tumor in the field so that the tumor should be in the field and I could be easily coagulating it little bit far from the important structures. So here again, I'm little bit cutting it piecemeal and excise the tumor again further from the base. So every time I try to take out the piece, it is started bleeding. It is the vascularity, the vascular supply from the base, it's actually giving its way. So I'm coagulating it gradually and making it small. Again, taking it out from the subfrontal portion of the left side. And these are the arachnoidal adhesions which I'm trying to cut gradually so that I can pull down the capsulated tumor with the arachnoidal dissection from the left side of the lesion. And now gradually I have started seeing the left side of the left optic nerve and trying to separate it gradually with the little bit pull on the tumor. Here again, I'm trying to take out whatever the part which is coming in my field of surgery gradually piecemeal and repeating the same steps. So here you can see that almost the tumor from the left side of the left interoptic space and the left side of the optic nerve, I'm trying to dissect it out with the suction and trying to break the arachnoidal adhesions. The beauty of this tumor is that it is encapsulated, and though it is not that much firm, so it's soft. That's why it is coming out easily. And you can see that with the good arachnoidal dissection, we can easily take out the tumor from the important structures, and gradually we can move ahead and ahead. So this is the time where you should not be in a hurry and you should not be coagulating the things which actually very much close by to the important structures like the optic nerve, optic chiasm. Here is the one band which is seen near about the right section of the optic nerve with the optic chiasm. So here I'm cutting that band, and while cutting the band, I'm trying to stage the tumor apart from the optic chiasm and the right sided junction. So small bleeding is also seen over there, but still I'm not trying to use the cautery over there. I'm trying to just push the optic chiasm. The surface of the tumor is having some sort of a supply which is actually bleeding. So it is said that some few of the small arachnoidal bands, they can carry blood vessels from the anterior cerebral artery also, apart from the basic supply from the anterior part of the dura. So here I am trying to bluntly dissect out the tumor from the optic nerve, right optic nerve. Little bit, I know that this patient is having a right PL positive, so I'm little bit to to do it in a hard way, but still I'm trying to pull out with the arachnoidal plane keeping intact. So here, after dissecting out from the right side, I'm trying to cut the portion, and every time I try to cut the portion in between the center of the tumor, the rest of the tumor automatically, when I start dissecting it out, it gets in the picture and gradually get dissected out easily from the arachnoids of the surrounding important structure. So here again, I'm trying to take out the posterior part of the tumor, which is actually in the subchiasmatic plane. Again, coagulating the base, again making it devascularized and trying to pull the tumor in the feed. So this is the part of the tumor which is actually in the, I'm taking out from the left-sided optic nerve and the left ICA also. So left ICA and left optic nerve was dissected out easily. You can see that there is a left ICA on the left side and small arachnoidal bands which are actually giving a small supply to the tumor surface is also getting little bit coagulated. And this part, after taking out this part, you can see that the left-sided optic nerve and left-sided ICA is getting cleared out. So many a times these tumors, the lobules of the tumors, they generally encase, and unless and until, as Atul sir's report was saying, that it is only the form tumors, they are generally gives the trouble to the vessel walls. So these soft and supple tumors, after taking out a good arachnoidal plane, can be taken out easily rather than the form tumors. The form tumors, they are generally adhered to the surrounding structures very firmly or they encase. Here you can see that the small arachnoidal bands I am cutting out and taking out the tumor. Now the intra-optic and rather chiasmatic portion of the tumor I am dissecting out, and here we have to be careful because the feeders or basically the important perforators from the anterior cerebral artery should not be disturbed. As well as we have to see that posteriorly it will be the hypochiasmatic tract will be there. So we have to be very much careful about the hypothalamo-pituitary tract also. So here I am again trying to dissect it out and taking it again piecemeal so that the posteriorly, now we can see that there is a hypophygeal tract can be seen, and trying to take out the arachnoidal adhesions from the tumor to the hypophygeal tract and trying to keep the arachnoid of the hypophygeal tract intact. So this stalk can be seen, and here I'm trying to pull it out. So the lobule around it can be taken out easily, so that encasing of the pituitary tract is also been made free. And I'm trying to take out the last portion, which is actually lying in the hypophygeal fossa. So this hypophygeal fossa tumor is also taken out. And gradually I'm again keeping the patience and trying to take out it again in a piecemeal fashion. So here basically we want to rather emphasize on the good arachnoidal dissection and preservation of the surrounding structures, the feeders, the perforators of all this zone, and without disturbing the normal anatomy, we have to take it out all around with the good covering of the patty, bottom patty. So this is the last portion of the tumor, and I'm trying to again do the coagulation at the base of this last portion. I'm trying to take out the small last part of the tumor. So these all globules, they are coming out easily, luckily, and without disturbing any much to the surrounding structure. So here I'm trying to take out, and yes, I want to emphasize on that small portion of the tumor, they remain lying inside the crevices around the tuberculum sali, and with those recessed part of the tuberculum sali, we have to take it out also. So I'm trying to take out this small portion from the base. Now I'm started coagulating and taking out the last few fragments of the tumor from the skull base, as well as I will focus more on to take out from the recesses. So I'll show you that after taking this, coagulating this base and taking out this part, I'm trying to see that the part which is actually going towards the recess of the optic canal and the internal carotid artery by the side of the tuberculum sali. So here you can see that I'm trying to take out that part also. So this is the small part which is in the recess. I'm trying to take it out so that there should be a complete excision. Rather, it will be a grade 2 Simpson's excision. And now we can visualize the internal carotid artery, even the PCOM can be seen, the third nerve can be seen. So all these structures can be visualized after completely emptying the salar region. And here you can see that the base, which is actually bleeding, I'm trying to coagulate it little bit. On the right side also, I'm trying to take out the tumor from the recesses, and the last part of the dura is getting coagulated. So this is the complete taking out of the tumor. This is the end point of the surgery, and you can see that all around, even the pituitary staff is seen nicely. There is a arachnoidal covering is also intact around the pituitary staff. I'm changing the view of my microscope, and I can you can see the left optic now, the left ICA, and the arachnoidal band around it, the chiasm, the PCOM, all these vessels can be seen nicely. So this is actually the end of the surgery. So third day, this patient was actually taking out the interview form. ये जो ऑपरेशन हुआ है, इससे आपकी आंखों की रोशनी ठीक है। So the take-home message from my presentation is that we have to really delineate the neurovascular structure surrounding the lesion. Again, the basics of the intratumoral decompression and the coagulation of the tumor base is very important. The third important thing is that we have to define the tumor capsule as much as possible and get it dissected towards the arachnoidal bands, and don't disturb the surrounding structures by extracoagulating. Thank you.
Thank you, sir. So now we will go to the second presentation, and then we can start. We will do the discussion for the both presentation. Dr. Kishore Chaudhary, sir, can you share your screen?
Yes, can you hear me?
Yes, sir. I
Yes,
can
sir.
hear you.
Okay, good. So what actually, let me see if I can.
Yeah, we can see your screen.
Okay, good. Sorry, I'm on a hospital computer, so it's very slow. Windows 7 still. So what I thought when Pramod asked me to speak on something as a case presentation a few days ago, that I thought that instead of showing my some of the very good cases that we all have, why don't I just show one of my recent complications? And when there are senior faculty members like Dr. Kiawat, who actually taught me how to use a microscope, and Atul, then there is no better learning opportunity for people like me to show my worst cases so that we can learn from their experience and insights. So one area that has consistently defied and defeated me in neurosurgery is high-grade glioma surgery in elderly. We are very careful in patient selection. We operate very well. We mean our team of neurosurgeons. We have 5 neurosurgeons who do oncology. And we give our best. We got a good infrastructure. But one thing we have constantly failed to achieve is beating the natural history of the condition. And I will show you one typical case that we normally do, and one recent case where we didn't do that well, and then have a discussion. So this is our management strategy here in Sheffield, that we have a review of case history and scan in a multidisciplinary team meeting every Wednesday, where oncologists, radiologists, pathologists, neurosurgeons, neuroradiologists, nursing team, psychologists all attend, and we come to a common consensus decision. Then the patient gets an outpatient appointment with a consultant neurosurgeon next day. They are also counseled by the specialist neuro-oncology nurses on the same day. Patient has a preoperative assessment by the anesthetist in a couple of days' time, and the patient has surgery and a post-op MRI scan within 48 hours. There's a bit of a delay. We have a long waiting list, and sometimes glioma patients they have to wait for 2 weeks, 3 weeks, and the patient that I'm going to show you had to wait for actually 5 to 6 weeks for surgery. unacceptable, but that happens. Then the patient has a review appointment for histology and further counseling, and then referred to oncology for radiotherapy, chemotherapy, and the patient is then followed up by oncologist, apart from one follow-up with the neurosurgeon. That's our structure, that's our system. It works very well, and we get about 60 patients per week referral of brain tumors. In elderly patients, we are a bit careful, like everyone is. We look at the Karnofsky performance scale, their pre-morbid medical history, their medications. We also do their cognitive assessment. And of course, patient and family wishes are also taken into consideration when making any decisions. Most of the literature is quite equivocal in management of malignant gliomas. The second table down, you can see on the right-hand side, the symptom-free interval and overall survival is less than a year, 9 months, 8 months, 6 months, 7 months in most of the cases in different parts of the world. And I must say, we have not been able to beat that. Just a typical case, what happens is this is an 80-year-old lady who's got a right-sided parieto-occipital tumor. It's a high-grade glioma. As you can see, she has been assessed and she's very fit and healthy generally. So we decided to offer her surgery. In fact, this lady was rock climbing when we saw her. And apart from a field defect, a little bit of field defect, not even complete, she didn't have any symptoms. So she was operated by parieto-occipital standard craniotomy and a radical excision of the tumor. And after tumor excision, this is our normal strategy for all gliomas. We try to achieve a supramarginal, radical, or gross total resection in practically every case, unless they are deep-seated. We have an immediate post-op contrast MRI scan, preferably within 24 hours, sometimes within 48 hours. And we encourage early mobilization and adjuvant treatment depending on their Karnofsky performance scale. So this was the patient the next day. As you can see, the drain also in her hand, and she was discharged in a couple of days after a scan. And the post-op scan, as you would expect, showed no abnormal enhancement in the scan, which we consider to be as a minimally acceptable outcome, radiological outcome. So basically, essentially a gross total resection proven by post-operative MRI scan as a standard protocol. We do not have to order it. It automatically happens. And we thought we did very well, but we didn't actually quite do that well. In about 7 to 8 months' time, she started getting symptoms, cognitive decline, and this was her scan despite complete resection in the first place. She had a recurrence at the previously operated site, and with cognitive decline, we decided that she was not fit for any further treatment, and she died after 13 and a half, actually 14 months. Sadly, I consider this as a very good outcome, considering my second case, which I'm going to show you now. Again, an elderly patient with a similar tumor, but this lady was a bit younger, 74 years old. She was also very fit and healthy, never been in the hospital before, no symptoms apart from a bit of tiredness, word finding difficulties, irritability, lack of appetite, etc. So this was her scan. This was in November 13th, actually, last year. As you can see, this is a large, deep-seated left frontal glioma. And in an coronal cuts, you can see that it's infiltrating even in the basal ganglia, although patient didn't have much symptoms from it. And if you can see, it is quite closely associated with the carotid bifurcation M1, A1, and the ventricular surface and the caudate nucleus, etc., etc. So we discussed about various options. Our opinions were divided. The patient's family were doctors, and she herself wanted something done. And we decided to offer her a decompression. Not a gross total resection, but decompression enough for her to make her fit for post-operative radiotherapy and chemotherapy. The patient agreed. Unfortunately, there was a waiting period for about 6 weeks from the date of decision was made, from the date of scan until she actually came for surgery. So this was the scan, a preoperative scan that we operated on. We debated what were the approaches Someone suggested, why don't you go transfrontally? We thought that splitting the Sylvian fissure would probably give better access because it's closer. Someone said, why don't you go transtemporally? But if you can see in the coronal scan, it's not a temporal tumor. It is all deep-seated frontal tumor. And we thought that going Sylvian or going transtemporal probably would only risk damaging the middle cerebral artery perforators and cause a deficits. So I decided to go frontally, but not actually directly transcortical. I went subfrontally through the gyrus rectus, enter the tumor, and then decompress it radically without trying to get rid of the excise the capsule. Just decompress the necrotic bit and the solid portion like this, and hope for the best and see. This was my plan. This is what we did. Radical debulking, about 80% of it was resected. Tumor was more extensive than the old scanner showed because 6 weeks had passed. The brain parenchyma was very diseased looking, yellow, oozy, friable. And at the end of the procedure, the brain was lax. Actually, it wasn't tense in the first place, but it looked very lusterless and pale. This was the post-operative course. Day 0 on the immediate post-op, she did not wake up as well as I had expected. Her Glasgow coma score, best GCS was 10. She had mild right-sided weakness. Next day, in the morning, she deteriorated to Glasgow coma score 7. We did a CT scan and we showed a clot in the tumor bed. She underwent re-exploration, and it was one of my senior registrar who did that. The clot was evacuated. Again, the brain was lax. Second day, she did not really recover, and we repeated the scan. And I will show you the scan again. And she also had an MRI scan, which was our standard protocol. On the day 3, her coma score deteriorated again. She had a seizure. Her both pupil fixed, and then we instituted palliative care, and she passed away peacefully on day 3. Now, this is the first post-op scan on the left side, which was on the next day morning of the scan. And it was not a senior registrar as a surgeon. This case, it was me. I was the surgeon, so I am to be blamed for this scan. And as you can see, there was extensive hemorrhage, patchy hemorrhage, not one particular clot, but generalized diffuse hemorrhage with some cerebral edema, and that explained her GCS of 7. So she was re-explored by my senior registrar, where the clot was taken out, the brain was lax, and a post-operative scan after the re-exploration was slightly better, but not much better, apart from some air and some residual clot. This is what we achieved. As you can see, the medial portion of the tumor and deep part of the tumor was still there. This was not a contrast scan, but again, she went on to have a MRI scan as a standard protocol. And as you can see, it shows subtotal resection, which is not usual in our case, but significant tumor left behind in the medial portion, also in the deeper portion near the caudate and the basal ganglia. And in the coronal scan, as you can see, significant portion of the tumor left behind with persistent edema. At this stage, we decided that perhaps it was not in our best interest to subject her to a third surgery within the span of 3 days, as we did not feel that the outcome would be different. So we just let her pass away peacefully without any further intervention. So we failed her. We did not achieve what we aimed to achieve. She should have gone home on the 4th day as normal with a better looking scan, and she should have had post-operative adjuvant treatment, but that did not happen. And in fact, I mean, many patients like this, even the first patient, sometimes I wonder whether the high-grade gliomas in elderly patients are more of a degenerative conditions actually than a tumor or neoplastic conditions. But again, that's for a discussion later on. So points to ponder in this particular case, the second case, which I would like all of you to focus on, that was open surgery justified? Should we have done only biopsy, or should we have just offered her palliative care? The family could have been persuaded whatever we wished, and whatever I would have advised, they would have accepted it. Should I have used a different surgical corridor? Should I have gone transcortically frontally? Or should I have gone through Sylvian fissure because it was coming more superficial? Was resection too conservative? We all vouch by gross total resection in most cases. But in this case, it wasn't meant to be. It wasn't aimed for. Was it too conservative? Or perhaps was it too radical because this was an incurable condition, unresectable tumor, at least in my hands, and I tried to be too radical and paid the price. Was the hemostasis adequate? We thought we did best, but it wasn't anything unusual but of course, when you don't remove the gliomas completely, swelling, edema, hemorrhage, these are the complications that they follow invariably. So probably even if it was hemostasis was adequate or not, if the tumor removal is not complete, it's always going to be inadequate. And was the delay in carrying out surgery after 6 weeks after the scan? Should I have repeated a scan and then decide again, review the case and decide whether what option would have been best? And should I have re-explored her again after the second exploration or MRI scan and removed that remaining part of the tumor, which was responsible for the third ventricular compression shift, because of which probably she passed away. So number of questions for me. I don't have an answer. Our colleagues have different opinions about every point that I'm pondering on. And in general, from this case, I wonder in elderly high-grade patients, does open surgical resection has any realistic possibility of changing natural history? I can't achieve it. Can anyone does? Should we do anything differently? And is best palliative or supportive care is the most appropriate way in deep-seated tumor like my second case? So that's all from me, guys. And I'm open for discussion and, of course, criticism. And who better than my teacher, Dr. Kiawat himself, or my friend Atul, to comment on this?
So we will discuss this case first. So I like Dr. Kiawat sir and Dr. Goyal sir to have their opinions.
So Kiawat is a little bit struggling with the computer. So let me make some points what I feel are important. You see, high-grade gliomas. We have been trained in high-grade gliomas when we were residents. We wanted to, if we were given a case, we were given high-grade gliomas to operate. And we learned radicality of resection. We learned how to remove the tumor. We learned how to achieve hemostasis. And we learned neurosurgery with high-grade gliomas and meningiomas. Basically, more radical we were, better a surgeon we were considered. On the other hand, low-grade gliomas was like a biopsy operation of 10 years ago at least. But now, in my opinion, what has changed is we have to be more radical and aggressive and radical, total this word, for low-grade gliomas. And this is universally accepted, whether it is in the supplementary motor area, whether it is in whatever area. We have to be radical and that is considered to be good for the longevity of life and for the quality of radical resection. On the other hand, we were more radical in high-grade gliomas, but now, as even Kishore has said, the question is how radical we should be and whether radical surgery, supra-radical and outside the dome of the tumor, that kind of radical surgery is indeed necessary. Is it radical or total resection? Is it possible? And I will invite Kishore to read one of my recent publications on radical resection of high-grade glioma. This was a smallish commentary which I had written, You see now what people are recommending, some of the, some publication, that we should go around the tumor. We should be hyper radical in high-grade gliomas. Is radical surgery necessary? Is radical surgery actually possible? So surgery for high gliomas is a different chapter now from what we were trained. We were trained to do radical, whether that training of radical and extra radical surgery, which some people recommend, is indeed necessary. My feeling is, you see, some of these high-grade gliomas, I have operated on one artist who was a beautiful painter and he had a left parietal glioma. I operated and I did a radical resection. But this guy was all right after surgery, but he could never resort to painting and to do high grade artistic work he was used to before operation. So, high grade gliomas have to be really assessed properly. This kind of insular high grade gliomas of the type which Kishore has shown, whether radical surgery is necessary or possible in these cases with good outcome. My feeling is, and biopsy, of course, is not an operation for high grade gliomas. We know what these tumors we are dealing with. There is no question of resorting to a biopsy operation, either radical or subtotal or conservatism. High grade gliomas is a difficult chapter in neurosurgery, and we can some of these tumors we can successfully remove. Majority of these tumors, high grade gliomas, are the ones where complications happen, and these complications, whether it is due to surgeon's neglect or whether it is inherent in glioma surgery, we have to decipher with each individual case. I think high grade gliomas is a unresolved issue in the subject of neurosurgery, whether you should use ALA to resect radically, whether it is actually necessary, whether our eyes are not good enough to resect high-grade gliomas, whether we should resort to using all these dyes and all these intraoperative for high-grade gliomas is a controversial issue in neurosurgery. My feeling is resect them radically when they are means we have to resect radically. I don't think there is any other option, but we should be knowing what can be the outcome, and we should keep the patient and the relatives well informed in these situations. I think this is what I would like to say. Kishore.
Thank you very much. Of course, Dr. Kiaut, sir.
See, the extent of resection is the most important independent prognostic factor in glioma GBM surgery. You had these two cases. In the first case, you resected it very well, although she was 80 years old. She did very well for 8 months. And it is a very good outcome for a GBM to survive for 8 months. So I think we should leave that case alone. I want to comment on your second case. In the second case, the worst thing was that you had to wait for many weeks. Despite the tumor, which was already deep-seated in the midline, causing mass effect, midline shift, and you have to wait. After having waited for such a long time, if the patient comes to you even in intact condition, I don't think I would have at least gone in for a major kinetomy and removing the tumor with the idea of doing gross total excision. It is like a sleeping lion. If you want to wake him up, you should be ready to kill it completely. Half killing the lion is no use because it is going to come back and attack at you. So even if your hemostasis was good in tumors which are not resected completely, you are going to face this problem, and we all face this problem of post-operative bleeding or post-operative edema and increase in the midline shift. So second case was a hopeless case actually. First case you did very well, and as Atul said, that all the techniques of removing all the gross total, whatever you do with your microscopic eyes, you can with eyes with your microscope, you can do only gross total resection. Unless you use 5-ALA fluorescence guided surgery, you can remove some more tumor, but when you remove some more tumor, you are going to end up at least in 25 to 30% of cases with more deficits. Maybe you'll improve survival in some cases. So I think my take home is that first case was very good. Second case, I would not have touched.
Oh, that's very kind of you, and thank you very much both Atul and sir for your opinions, and that's why I wanted to present rather than showing just the good cases you've done very well. Well, we do use 5-ALA in almost every case of high-grade glioma, and we are very radical in our approach in most cases. When they are young, fit, cortical tumors, superficial, well, everyone does very well, and there is no point in showing them. These are the difficult cases. The decision making is difficult, and you are not sure whether what will be the best outcome for the patient. And that's what makes it extremely challenging, because it is so disappointing when you don't end up achieving what you aim to achieve. And maybe these patients are going to die anyway, but even 6 months of symptom-free survival without any deficit is quite actually a valuable strategy for them, because they can sort out a number of things. And this time I failed, and for the benefit of all the younger generation as well, that when we operate and offer surgery for elderly people or for deep-seated tumor like this, someone like me who's been doing brain tumors twice a week for 30 odd years and still face these problems, I'm sure we have to think twice, review, reflect, and consider all the options before going in. So yes, thank you very much for your comment. Sarang, over to you.
Thank
So
you.
there
Sir,
are two questions for Dr. Kishore. One is whether the removal of bone flap was considered at the second surgery, and what should be the maximum age limit for the high-grade glioma surgery.
The first answer is simple. When there is a neurosurgical pathology intracranially, I do not remove the bone flap, and I don't let my registrar remove the bone flap. I instead ask them to treat the pathology and remove the pathology, whether it be a meningioma, a tumor, a brain intrinsic brain tumor, or a clot. It is my last resort to removing the bone flap, and there is a logistic reason behind that. Once we remove the bone flap in our institute, we are not allowed to put it in the abdomen or give it to the patient or store it in the freezer. We have to throw it away. And then the patient has to have a cranioplasty. And our current waiting list for a cranioplasty is 4 years at the moment. So that's unacceptable, but that's what it is. If a registrar calls me in the middle of the night that he's considering removal of bone flap, within 10 minutes, I'm there scrubbed in theater, because many a times it's just a sign of bad surgery that you're not removing the clot, you're not removing the tumor. So yes, we do not remove the bone flap, because I don't think it alters the outcome. In very, very few patients, it does alter the outcome for better. Second case is age. Again, that's very arbitrary. I did not mention any specific age, because for in our population, 75 years of age is not an old age. People, in fact, get married in their 60s. My own secretary got married when she was 55. So it's not uncommon for patients to have partners, go on lifelong voyages, go on world tours, go on trekking. Like this 80-year-old lady was rock climbing in Edinburgh, Scotland, at the age of 75, 80. So there is no, we have stopped putting a number onto the age. Sometimes chronological age may be young, but biologically they might be poor. Sometimes, as often, chronologically age may be in 70s and 80s. They may be octogenarians, but they are biologically very fit, and we treat them as such, biologically fit. But taking that point, I have still not been able to beat the natural history in people who are above 75. It just doesn't work in my hands. And with all the gadgets, all the radical approaches, and all the facility and help available, still I have not been able to beat the natural history in intrinsic gliomas in elderly patients. And this is with a large hundreds of patients being operated. So yes, does that answer the both questions?
Yeah, and there is one more question, that whether you follow the long axis of tumor to do the resection.
I do. What I do is I never rush in to go into the tumor. As I heard Atul speaking in one of the conferences a couple of years ago, I I always try and resist decompressing the tumor internally. I always find the plane. Almost always, there's a good plane. It's a false plane, but still a good plane between the brain parenchyma and the capsule or pseudocapsule of the tumor. So I try to achieve a good plane around it. Once I go up to the equator of the tumor, then I go into the tumor, decompress the necrotic part, and then the tumor capsule just falls in and then go around. The deeper portion of the tumor, which is often the medial portion of the tumor, is quite difficult to remove because the capsule becomes thin. The capsule requires good vascular supply, and medially, in the deep white matter, there is not much vascular supply as the cortex, so you will not get a good cortex. So we use 5-ALA and microscope, and sometimes in children's intraoperative MRI to achieve resections. But still, yes, I do go in the long axis of the tumor. Yes, I try to keep in the long axis of the tumor. But I do not go in the tumor unless I'm on the equator, dissected the tumor off.
Okay, thank you. I think this should answer the query. So now we will move to the first case,
Okay.
Dr. Giris's case.
Datta, Katikar has anything to say? Datta, Prasanna.
Sure. I had only asked you about the bone flap. I agree that because of your constraints of not giving the bone flap back, you are doing this. But looking at the second case, that you mentioned that the brain was looking lusterless and plain and and pale. And on the second time also, after removing the clot, also there is a lot of edema there. And in the first post-op scan, there is a lot of edema, midline shift, and mass effect. So will this be one of the exceptional cases in which you would consider removing the bone flap? Because we are in a very hard-pressed situation. We are fighting with our back to the wall. A patient who was fine has deteriorated, and we know that is because of a clot. So this was just a query because here, in case the brain is bulging, so we do consider removing the bone flap. As you correctly said, we can put it in the abdomen and put it back again, and those constraints are not with us. But technically speaking, because the scan showed so much of a mass effect and midline shift, so would you have considered if those constraints were not there?
Prasanna, actually, on both occasions, the brain was quite lax. And even if there is a shift on the scan, it did not appear to be a high pressure scan to remove bone flap. Our registrars are actually quite keen to remove them. The first thing they say is remove the bone flap so that they can get away without removing the tumor. But in these cases, on both the occasions, I was there. I wasn't scrubbed at the second time, but the brain appeared quite lax. So there was no reason to remove bone flap. But maybe your opinion probably is different, and maybe I don't know. I don't think it would have changed anything. I think the midline shift and the mass effect and the edema was because of not tumor removal. It wasn't because of the actually swelling of the cortex. So I didn't think it would have worked.
Sir, is it because of the venous edema or something like that? You think?
No, I am very careful about managing vasculature. There was no injury to any of the blood vessels. To be honest with you, in many glioma surgeries, I don't need to use the bipolar cautery. Once you got a plane, you are in the tumor, decompress it, resect the tumor, the bleeding automatically stops with a bit of pressure. I hardly use cautery. So no, I don't think we damage any of the blood vessels. It's just the disease, or maybe we didn't do it right. Something wasn't done right, and I can't blame any of my registrars or senior registrars, which I love to. But this time it was me who was the surgeon.
You went subfrontally,
That's
and
right.
that would have you went subfrontally, so that would have probably required more traction and retraction on the frontal lobe, because you go subfrontally and then you enter into the brain from below.
That's true. But when I do go subfrontally, like any terminal approach or supraorbital approach, I make sure that your craniotomy is very, very low, flush to the skull base, number one. And in this case, even at the stars, the brain was just swollen. So all we need is a couple of about 5 millimeters of space. So the retraction was used not to actually retract, just to identify the gyrus rector and the tumor surface. So there wasn't much retraction used. In fact, most of the cases, cortical tumors, I don't use retraction anymore for brain tumors, very rarely. In this case, retraction was used, but that was just to protect the cortical brain surface rather than actually retract the brain. So no, the gyrus rectus was found very easily. Entering it was not a problem. Finding a plane was not a problem. So yeah, and the cortex or brain were damaged.
Kishore, you would like to read one of my articles on the subject of removing such tumors by orbital surface, cortical incision, and going into the paraventricular tumor, like in your case. You please read that article. I think you will find some beautiful points, like parallel to the gyrus rectus and high-grade tumors and low-grade tumors, instead of coming transtemporally or transcortically, using the orbital cortical approach like you have used. But similar approach I had described about 10 or 15 years ago, and subsequently a big anatomical paper was written on the subject. And you please go through that. I will like you to read and comment.
Absolutely, Atul. I always love reading your articles, that like everyone else. But sure, yes, I will certainly go through it and reflect on it.
So let's move on to the first case, tuberculum semimeningioma. And Goel sir is here, who has published the largest series of 70 cases of tuberculum semimeningioma and also described the grading of the tumor system. So, sir, your comment on the first case, tuberculum semimeningioma.
Yeah, I indeed published this series on 70 cases in 2002. Now, after that, in 24 years, my series is beyond 325 cases, and which is indeed the largest series in the world. There is no question about it. I like this, tuberculum celli meningiomas are beautiful tumors to resect. And we have seen one case being done by Pramod, and it was very beautifully resected. Now you will ask me my strategy on dealing with tuberculum celli meningiomas. Instead of pterional approach, I use lateral, basal, frontal approach. Like my incision is just above laterally around the lateral aspect of the eyebrow. I don't like to use minimal invasive approach. I like to use little bit larger, not very big, but about largish exposure. My incision is never orbital eyebrow approach. I use this hairline approach incision. What is most important in tuberculum celli meningioma is the consistency of the tumor, the softness of the tumor. More than vascularity, consistency is the most important issue. Now the issue is what determines the consistency before operation. How will you decipher that this tumor is going to be difficult or not difficult? Most important issue, if you have read my article, is we have mentioned the degree of eye visual deficit, the degree. If the person is blind, the surgery is more difficult. If the person is just having marginal visual deficit, surgery is more easier. That is one criteria. Second thing is, duration of visual deficit is very important. If a person has visual deficit for 2 weeks or 3 weeks or 4 weeks, that tumor is different. And if the person is having visual deficit for 5 years, that tumor is much more firmer in consistency and more difficult to operate. So duration of visual deficit is a very important criteria which determines the consistency of the tumor. Third thing is encasement of the blood vessels. The entire operation of tuberculum celli meningioma is determined, the success is determined if you have taken one perforator of anterior cerebral artery during surgery and you have coagulated one, you can have a major deficit during operation. So what is important is identification of anterior cerebral artery very early in the operation and just not do any kind of, if you have injured a perforator, you can have a very major deficit. So from a very good outcome, you can have a very bad outcome of surgery if you damage the anterior cerebral artery perforator. So the whole operation, like for acoustic, the whole operation is based on facial nerve preservation. In tuberculum celli meningioma, the whole operation is based on preservation of blood vessels which come on the dome of the tumor and sometimes encasing the tumor. When the tumor encases the blood vessels, it is more often a soft tumor. And you can break the tumor, and deliver the tumor, even if the tumor has encased the blood vessels. And internal carotid artery encasement is not such a great issue, but anterior cerebral artery encasement of the ACOM artery region can be a little tricky thing to handle. But in such a situation, the tumor is more soft. Second thing is, if you have intratumoral calcification, intratumoral ossification, these tumors can become more difficult and you can have more issues during operation. If the tumor, the anostosis, like even in the case Pramod has shown, there was a big anostosis. If there is anostosis, these tumors are more firmer in nature. They are firm and breaking of the tumor can become difficult. If the patient presents with convulsion, that tumor is more difficult to operate. Usually these tumors come with visual deficit, but if tumor has come with a convulsion, there is edema around the tumor and it can be a little tricky. So I had made a classification system, smallish tumor, bigger neurological, if there is a small tumor and the patient has visual deficit which is more. So if the tumor is small, deficit is more, that is a firmer tumor. So I had given various criteria as to what determines the difficulty of the tumor resection. In my entire series, I have never got pituitary stalk injury, never. There is a beautiful arachnoidal plane and that plane has to be preserved. You have to learn the art of breaking the tumor, coagulate at the base of the tumor. Never try to coagulate within the confines of the tumor, because you can have unnecessary injury to the perforating vessel. Tuberculum meningioma can be more anterior towards the planum sphenoidal, can be more behind towards the diaphragm celli. So it can be ranging from one attachment to another, and difficulties range from where it is attached, size of the tumor, and various other issues. In general, tuberculum meningioma is a beautiful microneurosurgical operation. And if somebody says that I will remove it from the nose, I will say it is an absolutely not necessary and maybe a negative form of the treatment. First, come into the tumor, identify the optic nerve, work medial to the tumor, start breaking the tumor, release the optic nerves on both sides, then identify the anterior cerebral artery, then identify the perforators, then continue breaking the tumor, and when you have removed the tumor, then see the traverse of the tumor into the optic canal, and then if necessary open the optic canal. Otherwise it is not normally necessary to open the optic canal early in the operation. You can do it much later in the operation when the whole field is relaxed. I must say that it is not, there can be a big complication for surgery. If there is an anterior cerebral artery rent, you have to learn to suture the vessel. You cannot leave it bleeding and coagulate the vessel. You just cannot coagulate anterior cerebral artery. Coagulation of that can be highly dangerous. So if you need to suture, which is very rarely necessary, in my 300 cases or more than 300, I must have sutured not more than once or twice. But if it is necessary, you have to have a bigger exposure. If you keep a very small exposure and you have a bleeding complication during operation, then that suturing becomes difficult. So have a reasonable size exposure. Learn the art of breaking the tumor. These tuberculum meningiomas are really beautiful tumor to learn this art. Break the tumor, come at the base, dissect at the base, coagulate only at the base, not within the tumor, and of course not outside the tumor. I will say not one vessel is a feeding vessel on the dome of the tumor. If you think, oh, this is a feeding vessel on the dome of the tumor and I can coagulate, that is a wrong strategy. Never any vessel will come from the dome. Everything, whatever will bleed, will be from the base. I don't like to Simpson grade 2, as he mentioned. I like to do like that. I don't like to remove the anastosis until it is disturbing my operative line of direction. I don't like to do anything more. Removal of the basal dura, I never do. Removal of the basal bone, I never like to do. I like to remove the tumor, and beautifully, these are fantastic tumors, and I enjoyed watching Pramod's operation. Beautiful, he showed a fantastic microscopic view that he showed, and this is what we have to do, and this is a routine neurosurgical operation which we should do beautifully. So that is my comment.
Thank you, sir, for your compliment. Thank you.
Very well summarized, sir, everything. Dr. Kiawat, sir, your feedback.
Well, I was watching Dr. Giri. My my audio was not working, so I could not listen to what you said. But I could see your operation beautifully done, and it was a large tumor which you removed it very nicely.
Thank you.
So as Atul said, it is a beautiful operation, because when you see the MRI, you see as if it is just tumor is sitting on the plane surface, and you just go inside and take it out. The most important thing, as you said, is to catch the neck of the beast. Always go to the base of the tumor, as you did, and cut off the blood supply, and then go around the tumor and then take the vessels out, to separate the vessels out. The size of the tumor will decide which approach you should take. Usually, as Atul said, and as you did, I think I couldn't see your first thing. As you did a frontal approach, I think.
No, sir. Carry on.
No, I didn't see it from beginning. So terminal approach and frontal approaches are very good for tumors which are big and which are going into the optico-carotid recess and all that. But there are people who do minimally invasive supraorbital approaches where the tumors are not big, or when the base of the tumor is not very large. People go transnasally also, But I would say that the argument they say is that you don't have to retract the brain and you don't have to go intracranially. But that is what we are meant for. We are doing all the surgeries intracranially. We are doing all the surgeries, big tumors, difficult tumors intracranially. Why should we get scared of going inside the brain and retracting and go transnasally and create a lot of problem in the olfactory system and then have CSF like meningitis? You see, it's like going into the kitchen through the toilet. So I think we should avoid that intranasal thing. Although in many cases it can be done very nicely where the tumor base is small. But I think intracranially we shouldn't be scared of and going it. And more than that, I don't have to say anything. Atul has said a lot of things about it.
Giri sir, I just have one question that means I have read it in literature, not done, that when there is a small tuberculum cell meningioma on the medial aspect of the optic nerve, some people go from the contralateral supraorbital approach. Is it really necessary?
Rather, I don't have any experience about going on with it. So it's just every time I had done this, the same thing, that going on the worst side of the vision and taking the diurnal approach, subfrontal, and exposing in between the optic nerve at the base and start coagulating the base. That is the standard approach. But I ever used for my last 10, 15 cases. That's the only experience I am having. But definitely, Kishore sir can comment on this. So,
I mean, I use supraorbital approach regularly for these kind of meningiomas. But the thing with supraorbital approach is your craniotomy has to be perfect. So low skull base, not to worry about the front layer sinus, etc. Don't compromise on the approach. You don't have to do orbital roof approach. Just a regular low craniotomy suffices. And surprisingly, uh, under the microscope, a view using a pterional craniotomy and a supraorbital craniotomy, the deep view is actually the same. So you are doing the same operation just with a little smaller craniotomy. So actually, intradural deep-seated part of the surgery is same, and that's true for aneurysms as well. That if you are operating an intercommunicating artery aneurysm under microscope, when you zoom in, you are only focused to certain area, which is A1 and ACOM complex. With supraorbital approach, you are focused to the same area. So sometimes I even forget whether it's a pterional craniotomy or a supraorbital craniotomy because actually your operation remains the same. So it should not make much of a difference.
Sir, contralateral supraorbital approach.
I haven't done a contralateral supraorbital approach for a ipsilateral tumor. I have done it for aneurysms, but aneurysms are easier surgeries relatively because the anatomy is more or less fixed, number one, and the end point of surgery is relatively easy to achieve. In these patients, it's not that easy sometimes. In gliomas, even it's more difficult. There are more difficult surgeries than actually the meningiomas or aneurysms because you don't know what exactly the right endpoint is. And that's why I failed in the last cases. But I haven't done a ipsilateral tumor by a contralateral supraorbital approach. I'm sorry, no experience.
Okay, thank you, sir. Sir, the
I
closing
want to
comment
ask,
by, yes, there is one
I want
Sorry.
to ask
Yeah.
one question. Those who do small craniotomies like supraorbital, supraciliary, is there any advantage of doing a small craniotomy versus a larger craniotomy? What is the harm in doing a little larger craniotomy where you have more room to play and look around?
That's a good question, sir. Technically, in the outcome, there is no major advantage. But again, well, how should I say it? On my list, I can do two tumors, maybe two aneurysms. If I do supraorbital craniotomy, I can do three tumors. Opening closing is much quicker. Uh, Dura, you don't have to really close, put a piece of gel foam and all, and chances of CSF leak are quite low if you can take care of the front layer sinus. So you can focus and devote more time to the actual bit of the operation rather than opening closing. That's what I feel. Opening is 15 minutes, closing in 10 minutes. So if I want to spend 2 hours on the operation, I would rather spend it on the tumor or the aneurysm rather than spending half an hour each on the side of the actual operation. Does that make sense?
Yeah, okay. If you are
And
really
it's not
having such a
difficult.
long list every day, that makes a sense.
Yeah, and it's not difficult. It's less stressful. Yeah, closing is no time, 10 minutes, 5 minutes. And the junior most guy can do it, no problem. If I let the junior most or SHO to close my temporal craniotomies or terional craniotomies, once you drain the CSF and the dura is lax, I can guarantee you that I'll be coming home to now, I'll be coming back to theater for an external hematoma. That doesn't happen in supraorbital craniotomies.
Dr. Goel, your comments on this?
My comment is, of course, we should have a reasonable size craniotomy. But there was a saying earlier in my career, long time ago, and you must have heard it: bigger the surgeon, bigger the exposure. Have you heard this, Dilip, in your earlier career?
Great, yeah.
So
True.
I like to, regarding my exposure is of course not very big in any surgery, but eyebrow incision is I never take eyebrow incision. I take a behind the hairline. But if the hairline is like mine, there is no hairline, then you cannot take a occipital incision for a frontal operation. So I take within the frontal crease incision, and then I open and do
Prawn incision.
yes. So I do my burr is in the squamous here behind the orbital part of the zygomatic arch, behind under the muscle, and then I do a craniotomy like this. So my exposure is not very big, but not very small. And as I mentioned, one case I had where I had difficulty in suturing the vessel because my exposure was small. So I like to have a reasonable size, even if I know it is going to be a very straightforward, simple operation. But I like to have a little largish exposure, not a very small exposure, not a keyhole exposure and all those things. I don't like keyholes and all those kind of exposures for tuberculum semimeningioma or even for aneurysm. Even in aneurysm, sometimes I can do in keyhole. But when you have a real problem, maybe in 1 in 100 case or 2 in 100 cases, and when you are struggling with exposure, I think we have to have a reasonable size, not a huge, massive exposure, craniotomy, but not a keyhole or small buttonhole and all those things.
Very nice case demonstrations by Dr. Giri sir and Dr. Chaudhary sir, and very good discussion and expert comments by our esteemed panelists, Dr. Goyal sir and Dr. Kiawat sir. So I think we end the sessions here. Thank you, everyone. Good night.
Thank you. Thank you, sir.
Right.
Thank you, sir.
Thank you, Kishore sir. Thank you, Dilip sir. Thank you, Atul sir. Thank you.
Pramod, keep it up.
Sir, thank you, sir.
And you are, when I see the younger people, of course, like I'm not sure you will like to call yourself young anymore, my dear Pramod.
Yes.
But when I see you, I see the future of Indian neurosurgery, and we have to all do fantastic neurosurgery. We must know that our volume of cases is the largest in the world, as I showed you. Our technology, they showed beautiful microscope. We have fantastic imaging, all best coagulation, best suction. So there is no question if we have done 300, others in America have done 20. So how can you say they are, and we want to go and learn there? We should be learning all our neurosurgery in India. We can be the best. We are the best, and we should aim for higher platforms in our neurosurgical career. My best wishes to all from Maharashtra MCNS chapter, and we will show the world how neurosurgery is done. Okay, Pramod?
Thank
You promise?
Thank you, sir. Thank you, sir. And we will be more happy to have you as a panelist in next sessions also, sir. Thank you.
Thank you.
Kishore,
Yes, sir.
you can send your cranioplastics to India. 4 years is a very long period to have a sunken flap and have a lot of complications. Send them to India. We'll do them fast and send them back.
Well, if that's any, we got a 2,500 patients waiting for an outpatient appointment who have got proven cervical or lumbar disc. And that's why I'm sitting in a clinic today doing an OPD from 7:30 in the morning until I'll be doing at 5:30 in the evening, because we got such a backlog of about 2,600 patients waiting for only simple spine operations to be seen. The ones they are seen, the waiting list for, there are 700 patients who are on the waiting list for cervical disc or lumbar disc or decompression. So cranioplasty is a small number.
So you must be having the largest series of conservative management of cervical and lumbar disc.
That's
And outcome.
that's correct. That's correct. Most of the patients of lumbar disc who have been waiting for long, 9 out of 10 are better on their own and don't
They
need
get all
anything.
right. Yeah.
Thank you.
That's true.
Thank you.
Absolutely. Okay.
Thank you, everyone.
Okay. Thank you. Good night.
Bye.
Good
Good
night.
night.
Good night.
Good night.